Hello, this is Dr. Stephen Morris, and I'm starting the lecture series for Anatomy Physiology 1. Today we'll be discussing the integumentary system. Again, this is a continuation of the lecture series for A&P 1. Now, this is an illustration from your textbook that demonstrates the components of the integumentary system. For the purposes of the lecture exam, obviously you'll have to appreciate the functions of each of these various components in this cross-sectional picture of the integumentary system. For the purpose of the practical lab examinations, you will be able to, or you should be able to identify the structures as listed on this illustration. Basically, when we talk about the components of the integumentary system, I like to point out that the various levels, the epidermis being the most superior aspect, just inferior to the epidermis is the papillary layer. Following that is the reticular layer. As you can see, the papillary layer and the reticular layer both go to make up the dermis, and then inferior or lying deep to the dermis, which includes papillary layer and the reticular layer, is the subcutaneous tissue. Some of the structures I'd like to point out to you to help to identify are first this shaft of hair, and as you can see, the blood circulation, the small arterioles and the small venules that actually feed the root of the hair shaft, here illustrated here. There are tactile corpuscles that we will discuss later on in the lecture. Ducts that lead from sweat glands. There are a number of sweat glands that are located throughout the integumentary system. Again, as you can see, they lie more in the dermis layer. And then, as I said, in the subcutaneous layer, you can see the blood vessels. One point to make out for clinical relevance is that when an injection is given into the subcutaneous layer, it is typically administered in this area because the blood supply here is significant, and so medications that are injected into the subcutaneous layer are able to be absorbed into the bloodstream a lot quicker. Now, there are 6 general functions of the skin and the subcutaneous layer, and I would expect you to be able to identify these 6 functions. They include protection of the underlying tissues and organs against shocks, abrasions, and chemical attack. There's also an excretion function, excretion of salt, water, organic waste by the integumentary glands. Also, there is maintenance of normal body temperature through either insulation or evaporation or evaporative cooling, and that's done as needed. Other functions include synthesis of vitamins, steroids that are subsequently converted to hormones such as calcitriol, important in normal calcium metabolism. When we talk more about the endocrine system, we'll talk more about calcitriol and calcium metabolism. The other function of the integumentary system would be storage of nutrients. Lipids are stored in adipocytes, which are located in the dermis, and in the adipose tissue in the subcutaneous layer. Also, the integumentary system functions for detection of touch, pressure, pain, and temperature, stimuli, and the relaying of that information to the nervous system. When we go into detail about the nervous system in A&P Part 2, you'll see how the nervous system receives information from the external environment. The receptors for that are primarily located in the integumentary system, and you will see the importance of that, again, which will be considered later on in further discussions. Again, cutaneous senses, which provide information about the external environment, will be considered when we go through Chapter 15, which is a portion of the nervous system. This illustration, taken from your textbook, demonstrates the level of the epidermis, as you can see here in the illustration. Also the epidermal ridge, the dermal papilla, which we'll talk about more, and the dermis layer. You see this, and you've looked at the histological slides before. You recognize this as being stratified squamous epithelial tissue, some of which has significant more callus formations than others. You can also appreciate the dermis layer and the epidermis layer located in each of these histological slides. Which brings us to the point of thin skin and thick skin. Thin skin covers most of the exposed body surfaces. Thick skin covers the surfaces of the palms and the soles. If you can identify, the palms and the soles typically have more contact with the external environment as far as abrasive surfaces, and so callus formations or thick skin is necessary to be able to have this repetitive contact with the external environment. There are cells in the integumentary system referred to as keratinocytes. The body's most abundant epithelial cells are referred to as keratinocytes. The precise boundaries between these layers can be difficult to see under light microscopy. Certainly under higher magnification, it can be certainly identified even better. Thick skin is located on the palms of the hands, the soles of the feet. 5 layers can be easily distinguished. Thin skin that covers the rest of the body, only 4 layers are recognizable. The term thick and thin refer to the relative thickness of the epidermis and not to the integumentary as a whole. And you can see that on previous illustrations and histological slides, where again the actual layer of the epidermis remains the same, but the development of this thick skin, the callus formations that we see, may vary in their size or their depth, but the epidermis basically remains the same. Now, epidermal ridges of the thick skin. Those of you who appreciate CSI will appreciate this. Fingerprints reveal a pattern of the epidermal ridges. The pits that are openings of ducts of American glands are located in the pits formed by these epidermal ridges. This is basically what gives us the pattern of a fingerprint. As you can see, there are epidermal ridges. These are the dark lines that you see in the typical fingerprint. But then between these dark lines, you see these little tiny pores. This is from American, if I can say the word, American secretions. Little oil, little moisture, comes from these little pores. This leaves a residue on surfaces that we touch. That residue can be identified by crime labs and other agencies, because they leave a residue, they're able to be chemically identified and patterned to give a specific image to identify a person. Now, layers of the skin, all of the layers of the skin, you will be responsible for being able to identify these in your anatomy labs. You should be able to identify each of the following layers: the stratum germinativum, the stratum spinosum, the stratum granulosum, the stratum lucidum, and the stratum corneum. We'll go through each of these layers. Each of these specific layers has a role. There are specific cell types in each one of these layers, and we'll discuss them a little more in detail. But you should be able to identify these specific surfaces in the integumentary system. This illustration is taken from your book, and again, you should be able to identify each of the structures of the integumentary system, primarily of the epidermis. They include, again, the stratum corneum, stratum lucidum, stratum granulosum, stratum spinosum, stratum germinativum. Also, you should be able to identify the basal lamina, where the basal lamina starts, and then also the dermis. Please recognize again how deep the dermis lies in comparison to the other layers. Now again, if we look at this grossly, obviously we don't see this thickness when we look at our skin. But if you look at it under microscopy, you can appreciate each of these layers. Now, a portion of the epidermis is the thick skin, showing the major stratified layers of epidermal cells. Now, Langerhans cells, which we'll talk about a little more in detail later on, Langerhans cells cannot be distinguished in the standard histological preparation. These are special cells that are located, carry out a special function. And again, I'll talk about Langerhans cells more in subsequent slides. The innermost epidermal layer is the stratum germinativum. The stratum germinativum forms the epidermal ridges, which extend into the dermis, increasing the surface area in contact between the two regions. The dermal papillae, basically dermal projections They can be singular, papular, or a nipple-shaped mound. It extends between the adjacent epidermal ridges. This is an interlocking arrangement which increases the strength and the bond between the epidermis and the dermis. The strength of the attachment is proportional to the surface area of the basal lamina. The more folds, the larger the surface area becomes. Large basal cells, also known as germinative cells, they dominate in the stratum germinativum. Basal cells are basically the stem cells whose division replace the more superficial keratinocytes that are lost or shed at the epidermal surface. Now, recognized in the skin, because it's exposed to the external environment, these cells have a shorter life than some other cells in our body. And because of that, there needs to be a line of stem cells that can continually divide and provide new cells to replace those cells which have been lost. Another cell type is called Merkel cells. Skin surfaces that lack hair also contain specialized epithelial cells known as Merkel cells. Merkel cells are scattered among the cells of the stratum germinativum. Merkel cells are sensitive to touch. When compressed, they release chemicals that stimulate sensory nerve endings. These sensory nerve endings send the signal back to the brain that help the brain to interpret what the environmental stimulus is. Another cell type referred to as melanocytes. Melanocytes are basically brown tones of skin and result from synthetic activities of pigment cells. These are referred to as melanocytes. They're distributed throughout the stratum germinativum with cell processes extending into more superficial layers. The stratum spinosum, each time a stem cell divides, one of the daughter cells is pushed superficial to the stratum germinativum into the stratum spinosum. It consists of 8 to 10 layers of cells with keratinocytes bound together by desmosomes. Some of the cells entering this layer from the stratum germinativum continue to divide, further increasing the thickness of the epithelium. Now, Langerhans cells, which I alluded to a little bit earlier, basically the stratum spinosum contains these Langerhans cells. They participate in an immune response. They are responsible for stimulating a defense against microorganisms that manage to penetrate through the superficial layers of the epidermis, and then they also are involved in superficial skin cancers. The stratum granulosum, this is a region that's superficial to the stratum spinosum. This is the stratum granulosum. The stratum granulosum consists of 3 to 5 layers of keratinocytes displaced from the stratum spinosum. By the time cells reach this layer, most have stopped dividing. They begin making large amounts of proteins, keratin, and keratohyalin. Now, keratin is a tough, fibrous protein. It's the basic structural component of hair and nails. As keratin fibers develop, the cells grow thinner, flatter, and their membranes thickening and become less permeable. Keratohyalin forms dense granules in the cytoplasm that promote dehydration of cell. It also promotes aggregation and cross-linking of keratin fibers. The nuclei and other organelles that disintegrate as the cell dies. Further, dehydration creates tightly interlocking layers of cells that consist of keratin fibers surrounded by keratohyalin. Stratum lucidum. In the thick skin of the palms and the soles, a glassy stratum lucidum, which is basically a clear layer, covers the stratum granulosum. The cells in the stratum lucidum are flattened, densely packed, and filled with keratin. In the stratum corneum, at the exposed surface of both thick skin and thin skin is the stratum corneum. It normally contains 15 to 30 layers of keratinized cells. The stratum corneum is water resistant, but it's not waterproof. Water from interstitial fluid slowly penetrates the surface to be evaporated into the surrounding air. Keratinization. This is also known as cornification. This is the formation of a protective superficial layers of cells filled with keratin. The process occurs on all surfaces of the skin or all exposed skin surfaces except the anterior surface of the eye. Now, this is important to recognize. because on the anterior surface of the eye, if it went through a process of keratinization or cornification, then the covering of the eye would basically become opaque, and then we would not be able to focus light on our retina, and thus we would not be able to see. So again, cornification or keratinization takes place on all the surfaces or superficial layers of the skin, with the exception of the surface of the eye, the anterior surface of the eye. Now, dead cells in each layer of the stratum corneum remain tightly interconnected by desmosomes. If you remember earlier in previous lectures, we talked about intracellular connections, desmosomes, hemiadesmosomes, tight junctions. So the dead cells in each of these layers of the stratum corneum will remain tightly interconnected. The connections are so secure that keratinized cells generally, when they die and shed off, will shed off in large groups or sheets rather than individually. A good example of that is when you go out and suntan, and then days later you begin to peel. You don't peel off one individual cell. Well, actually, I guess you can possibly shed off one individual cell, but typically it sheds off in sheets. There are sheets of dead cells because the hemiadesmosomes are very resilient and will remain interconnected. It takes about 15 to 30 days for a cell to move from the stratum germinatizum to the stratum corneum. Dead cells generally remain in the exposed stratum corneum layer for an additional 2 weeks before they're shed or washed away. Now, insensible perspiration. Again, remember when we talked about homeostasis in the human body, I alluded to the integumentary system. One of the important roles in homeostasis is the maintenance of fluid levels and the maintenance of temperature. When we talk specifically about fluid levels, understand the importance of the integumentary system. Now, through the integumentary system, you can have insensible perspiration. You can roughly lose about 500 cc's or 500 milliliters, which is approximately 1 pint of water in this way each day. The process, referred to as insensible perspiration, because it's to be distinguished from sensible perspiration, which is produced by active sweat glands. So just to wake up in the morning and to carry out your normal activities of daily living, no stressful exercise, no running, no jogging, basically just to carry out normal activities of daily living, we lose about 500 cc's or 500 milliliters of fluid. Now, this is not fluid that we can recognizably see. The fluid is lost through perspiration, but it doesn't accumulate in a sense of moisture on the skin as you would see with active sweat glands. But this is moisture that's lost through the integumentary system. Now, any damage to the epidermis will then increase the rate of insensible perspiration. If you damage or break the connections between superficial or deep layers of the epidermis, then fluid can accumulate in pockets, which would be referred to as blisters, or you can completely damage the surfaces of the epidermis, which can cause significant loss of fluid to the external environment. This basically causes the stratum corneum to lose its effectiveness as a water barrier, and the rate of insensible perspiration skyrockets. Now, in burn patients, this is a significant problem. The integumentary system has been completely lost or completely destroyed, and thus significant amount of fluid is lost through insensible perspiration in patients who have undergone burns. There are some extreme skin conditions which you should be familiar with. One is referred to as xerosis. Xerosis refers to excessively dry skin. This typically can be exacerbated by hypertonic conditions or hypotonic conditions, depending upon the environment. And now we'll change to another topic referred to basically as skin color and the factors that are involved in skin color for various individuals. The color of your skin is a result of an interaction between two important components: epidermal pigmentation and dermal circulation. Again, interaction between two specific functions are epidermal pigmentation and dermal circulation. Skin pigments, the epidermis contains various quantities of skin pigments. Two primary pigments that we are concerned about in the human body are keratin and melanin. Keratin basically is an orange-yellow pigment that normally accumulates in the epidermal cells. It is most apparent in cells of the stratum corneum and most obvious in patients or individuals of light-skinned individuals. Keratin can be converted to vitamin A. This is required for the normal maintenance of the epithelial and then the synthesis of photoreceptor pigments in the eye. So it has some other important functions and roles as well. Melanin is a brown pigment or a yellow-brown pigment, or in some cases can even be a dark or black pigment produced by melanocytes. We showed some slides early on, histological slides early on, that demonstrated melanin as well. And we'll go into a little more detail, and I'll show you some more slides representative of melanocytes later in the lecture. Melanocytes are located in the stratum germatium. They're squeezed between or are deep to the epithelial cells. Manufacture the pigment of melanin from molecules of amino acids tyrosine. And the melanin is packaged in intracellular vessels referred to as melanosomes. These vesicles will then travel within the processes of the melanocytes and then transfer intact to keratinocytes. These are illustrations and histological slides from your text. Again, you can appreciate the melanocytes which are lying here in the stratum germatium. This illustration is representative of a melanocyte. As you can see, the finger-like processes of this melanocyte, the vesicles that will be pinched off or break off and will travel superiorly to give skin color to individuals. These are the melanosomes, vesicles filled with the pigment. Now, we'll talk a little bit about damages that can occur, or damage that can occur to the integumentary system. One of the primary environmental factors that can damage the skin is UV radiation. UV radiation can damage DNA, causes mutations, and then promotes cancer. Skin cancers can develop from chromosomal damage in the germinative cells or in the melanocytes. Cumulative damage to the integument by UV exposure can harm fibroblasts, causing impaired maintenance of the dermis. The resulting structural alterations lead to premature wrinkling. UV radiation can also produce an intermediate effect of mild or even serious burns, damaging both the epidermis and the dermis. Now, you can avoid some of the UV radiation by a variety of protection techniques. Obviously, from exogenously, we can apply sunscreen, sunblock, protective clothing to help protect our skin. In the keratinocytes, melasomes become concentrated in regions around the nucleus where melanin pigments provide some UV protection for the DNA in those cells. The presence of a layer of pigment in the deep layers of the epidermis helps protect both epidermal and dermal tissues. Now, this is why pigmented individuals, especially individuals with darker melanocytes, darker pigments, melanin, have a tendency to have less, and I mean less instance of skin cancers. Now, it does not mean these individuals will not suffer from skin cancer, but certainly the frequency of it is lessened because of the protective value that the pigment can provide to the skin. Now, there are different forms of skin cancers, and we'll go into a little detail about each one of them. And then in a subsequent lecture, you'll get a lot more detail about various skin cancers. The first one is basal cell carcinoma. This is a malignant cancer that originates in the stratum germatium. Most common skin cancer that affects individuals. Metastasis virtually never occurs. 2/3 of these cancers appear in the body area subjected to chronic UV exposure. There are genetic factors that have been identified that predispose certain people to this condition. This is a picture that illustrates to you basal cell skin cancer, and it's given in comparison with melanoma. As you can see, the appearance of the basal cell cancer is more of a flesh tone. You can delineate a border, but the pigment of this and the appearance of this lesion is very similar to the skin. It's slightly raised. You can see it, you can appreciate it in the photograph. There is some mild, slight ulcerations noted at the surface of this lesion. Melanoma has a much different appearance. As you can see, this is a moist appearance. This is necrotic tissue that is formed because the melanoma has invaded and probably has cut off the blood supply under the skin, and so you have basically a moist necrotic lesion here in appearance. Again, we will go into more detail about basal cell carcinomas and about melanomas in subsequent lectures, but for now we'll just briefly touch upon each one of these topics. Another type of skin cancer is squamous cell carcinoma. Less common, almost totally restricted to the area that's sun exposed. Metastasis seldom occurs in squamous cell carcinomas. Treatment typically involves surgical removal. Malignant melanomas are extremely dangerous cancers. Cancerous melanocytes grow relatively rapidly. They metastasize through the lymphatic system. The lymphatic system is just another form of a circulatory system in the human body. It complements the circulatory system and primarily carries fluid and primarily carries fluid and also carries immune cells to help in the defense of the system. If cancers are localized, the 5-year survival rate is about 99%. That means if 100 people are diagnosed with malignant melanoma, and it's a localized lesion, in other words, it has not spread to any other area, then in 5 years, 99 of those people will still be alive. Only one of those individuals will have died from malignant melanoma. Now, at the time of diagnosis, if the malignant melanoma is widespread, in other words, it's not only involving the integumentary system, but may involve another organ system as well, the lungs, the liver, multiple remote lesions in the integumentary system, then the melanoma is considered to be widespread, and the survival rate drops to 14%, meaning that 100 people diagnosed with malignant melanoma that is widespread at the time of diagnosis, in 5 years, only 14 of those people will be alive. Hopefully that will indicate to you the importance of doing skin assessments, not only on yourself, especially if you're a sun lover, but also on the patient population. Important to identify dark, pigmented areas on the skin. Some of these may simply be moles, but it is important to document that mole. It's also important, and individuals themselves should take a photograph of that mole. And then in subsequent examinations, 5 years later, you're in the doctor's office and he notices that mole and he says, maybe I should do a biopsy of that mole. You'll have a picture of it. He'll be able to see whether or not it has truly changed or not. If the mole has stayed the same over 5 years, then it's obviously a benign mole and won't cause any problems. So I always emphasize that to patients that I see in clinic, especially if they have a dark, pigmented mole and they've had it since childhood, but now as an adult and they may be suntanning a lot more. They're concerned that it may be a problem. I actually ask them if they have any previous photographs, or I'll actually take a photograph in the office and follow that over a period of time. If the mole is causing a problem, or if the pigmented lesion is causing a problem, it's irritated, it may be bleeding, then obviously that's an indication to go ahead and do a biopsy on it. But if it has not changed over a number of years, then it's probably a benign lesion, and you can probably just follow that up in clinic. Now, again, this just touches upon the importance of early detection in melanoma. Some of the things you can look for in a clinical setting, and so when you're doing an assessment on a patient, you may want to look for the symmetry or asymmetry basically of this lesion. Again, this is the ABCDs, I should have said that. The A is basically the asymmetry. Melanomas tend to be irregular in shape. Typically, they're raised. They may ooze or bleed. As you saw in the previous picture, they have kind of a necrotic or a wet necrotic appearance. B is for the border. The border of a melanoma is generally unclear, irregular, in some cases notched. C is for color. A melanoma is generally mottled with many colors, any combination of tan, brown, black, red, pink, white, or blue. And D is for diameter. The growth of more than 5 millimeters in diameter, or roughly the area covered by the eraser of a pencil, is typically dangerous. There are new treatments for melanoma. Genetic engineering technology certainly has made a lot of strides in the last several years. There's the manufacture of antibiotics that can target melanocyte-stimulating hormones. It basically it basically targets the receptors for this hormone on the surface of the melanocytes. Thus, melanocytes won't grow. Melanocytes are coated with antibodies that are recognized and attacked by cells of the immune system. Now, dermal circulation. Blood contains red blood cells that are filled with pigments referred to as hemoglobin. Now, when bound to oxygen, hemoglobin gives a bright red appearance, giving blood vessels in the dermis a reddish tint, which is most apparent in individuals that are lightly pigmented. Hemoglobin, when it releases the oxygen, actually the individuals turn darker, a darker red, or sometimes a bluish discoloration. Another term I talk about is called cyanosis, and this is also a very important and relevant clinical term. Skin takes on a bluish discoloration in this particular type of sign. Individuals of any skin color, cyanosis is the most apparent in the area of thin skin, such as the lips or beneath the nail. It can occur in response to extreme cold or as a result of circulatory or respiratory disorders. Cyanosis, let me just go back to cyanosis just for a minute. Cyanosis is very important for you to be able to identify in a clinical setting. Individuals that are having problems with oxygenation or getting adequate amount of oxygen to the tissue areas will develop cyanosis. And so it's a clinical sign of extreme concern, unless, of course, it's a result of the environment, and as shown on the slide as well, in extreme environmental conditions such as extreme cold, there's a response of the circulatory system to constrict the superficial blood vessels, which will deprive the superficial tissue of oxygen, and thus you'll see a bluish discoloration. But you expect to see that in an extremely cold environment. In a clinical setting, if you see cyanosis, it typically is indicative of a problem, sometimes a problem to a degree that requires life-saving measures to be taken. Another form of pigmentation is referred to as freckles. These are small areas of pigment on the skin, especially in pale-skinned individuals. Typically, they have irregular borders, melanocytes that are producing larger than average amounts of melanin. Freckles tend to be most abundant on the sun-exposed surfaces of the face, shoulders, and arms. Diseases that have primary impacts on other systems may have secondary effects on the skin color or pigmentation, and we'll mention a few of those diseases now. These are the diseases that can impact pigment. You should be familiar with these, and we'll discuss these a little further in some subsequent lectures. One of which is jaundice. This is typically seen in individuals with liver disease. Jaundice occurs when the liver is unable to excrete bile. Now, bile is a substance that's produced in the liver. It has a yellowish pigment. Bile is usually transported from the liver to the small bowel, or the duodenum of the small bowel, which is an organ involved in digestion, comes off the stomach, and the bowel helps in the breakdown of lipids that are ingested in our diet. However, if there's an obstruction in the biliary tract, the tube that leads from the liver to the small bowel, then jaundice will occur from the accumulation or the backup of bile in the system. In advanced stages, the skin and the sclera, or the whites of the eyes, will turn extremely yellow. In pigmented individuals, especially dark pigmented individuals, sometimes the best area to do assessments are in the sclera of the eye. Now, some tumors that affect the pituitary gland can also affect pigmentation. Again, it typically stimulates or affects the large amounts of melanocyte-stimulating hormone, or MSH. This hormone causes a darkening of the skin, as individuals have extremely bronze tan. Another condition referred to as Addison's disease. Addison's disease, the pituitary gland secretes large quantities of adrenochromatopic hormone, ACTH, a hormone that is structurally similar to melanocyte-stimulating hormone. These individuals will also get a change in pigmentation. Another disease that you may have heard of that has received a significant amount of attention in the last several years is called vitiligo. This is the loss of melanocytes. Thyroid gland disorders, Addison's disease, immune defense dysfunction, where the antibodies actually attack the melanocytes, leads to a loss of the melanocytes. The primary problem with vitiligo is cosmetic, though with the loss of the melanocytes, obviously you're more sun sensitive. Now, this is the disease, and the reason why it has obtained, well, one of the reasons why it's obtained a lot of popularity is this is what Michael Jackson suffers from, vitiligo. Now, the dermis. This layer lies between the epidermis and the subcutaneous layer. The dermis has two major components, a superficial papillary layer and then a deeper reticular layer. The dermal organization, the papillary layer consists of areola tissue. This is a region that contains capillaries, sensory neurons that supply the surface of the skin. The reticular layer, deep to the papillary layer, consists of interwoven meshworks of dense, irregular connective tissue. Collagen extends to the reticular layer and blends into the superficial papillary layer. The boundary between the two layers is basically indistinct. The reticular and the papillary layers of the dermis contain a network of blood vessels, lymph vessels, and nerve fibers. The dermis contains all the cells of the connective tissue proper. Accessory organs of the epidermal origin, such as hair follicles and sweat glands, extend into the dermis. Another condition, again, that we'll discuss more in detail in some subsequent lectures, is referred to as dermatitis. Dermatitis is an inflammation of the skin that primarily involves the papillary layer. Inflammation typically begins on a part of the skin that's exposed to either infection or irritated by chemical, radiation, or mechanical stimuli. Dermatitis may cause itching. It may or may not be associated with pain. It depends on the severity of the condition. Now, dehydration in the skin. The water content of the skin also helps maintain its flexible resilience, properties collectively known as skin turgor. Symptoms of dehydration is the loss of skin turgor. Aging, hormones, UV radiation, destructive effects reduce the amount of the elastin, which is the stretchiness in the dermis. This produces wrinkles or sagging skin. Now, there are also some changes in the integumentary system due to pregnancy and the dermis. There's an extensive distortion of the dermis as it occurs in the abdomen during pregnancy or after substantial weight gain that exceeds the elastic capability of the skin. This results in damage to the dermis, and it prevents it from recoiling to its original size after delivering or after the person has lost weight. The skin will then be wrinkled, creased, and may even have a network of areas referred to as stretch marks. Now, stretch marks, again, are actually a break in the elastin that's in the integumentary system. If you break this elastin, it is very difficult for that area to recover completely. Individuals who suffer from stretch marks spend millions of dollars every year looking for the miracle cure for stretch marks. There is none. Once those elastin fibers are broken, you can cosmetically cover them up with various creams and preparations, but the damage to the integumentary system is already there. Now, there are some substances that have been used that can be applied to the skin that will help at least reduce some of the rate of wrinkling or loss of this, the texture of the skin. One of these substances is referred to as trinitine. This substance is derived from vitamin A, can be applied to the skin as a cream or a gel. The drug originally was developed to treat acne, but it also increases blood flow to the dermis and stimulates dermal repair. As a result, the rate of wrinkle formation decreases and existing wrinkles can become somewhat smaller. Now, this is not a miracle cure. It does not work as a facelift would work, but for small wrinkles, small fine wrinkles, you can see some noticeable improvements by using trinitine. The wrinkle rate, certainly if you use it before wrinkle formation starts, the rate of wrinkling will significantly decrease. Another concept that I want you to appreciate is what's referred to as cleavage lines of the skin. These are lines of cleavage that follow a specific pattern of fiber or bundle in the skin. They reflect the orientation of the collagen fibers that bundle in the dermis. Clinically, this is more significant for surgeons. Typically, when incisions are made, they're made along these lines of cleavage. An example is when an individual undergoes an appendectomy. An incision is usually made in a diagonal fashion here across the abdomen in the right lower quadrant because it follows that cleavage line. Similarly, an inguinal hernia would be made along this, if I can get the arrow to sit still, typically an incision would be made in this inguinal region and would be made in a diagonal fashion. If you remove the gallbladder, gallbladder lies in the right upper quadrant. Again, an incision would be made along the cleavage line of the right upper quadrant. Other surgical procedures, such as removing a lung, doing open heart surgery, sometimes it's done along the cleavage line, or probably removing a lung. I suppose open heart surgery actually probably doesn't fit this illustration because open heart surgery would involve a midline incision to expose the sternum and the heart. So, but certainly to remove a lung or to remove a lobe of the lung, incisions would be made along these various cleavage lines. Now, back to circulation again and the cutaneous plexus. Arteries supplying the skin form a network in the subcutaneous layer along its border with the reticular layer of the dermis. Tributaries of these arteries supply the adipose tissue of subcutaneous layer and the tissues of the integumentary system. At the papillary layer, the small arteries form another branching network, the papillary plexus, which provides arterial blood to the capillary loops and follows the contours of the epidermis and the dermis boundary. These capillaries empty into a network of small veins that form a venous plexus deep to the papillary plexus. The rupture of dermal blood vessel can occur. Blood leaks into the dermis, and that's where you see the black and blue marks. So again, it's the cutaneous plexus, it's the damage of the dermal blood vessels, accumulates or leaks into the dermis, and that's how a bruise would accumulate. A bruise is basically a coagulation of blood or a collection of blood that has leaked into the dermis. This illustration, again, is out of your book. Demonstrates the papillary layer and the reticular layer, but it also demonstrates the subcutaneous plexus. Again, as you can see, there are arterioles and veins that are located in the subcutaneous plexus. They do have tributaries that will feed more superficial structures, but for the purposes of absorption of specific medications, they have to be injected into the hypodermis, or below the dermis, the hypodermis area, or into the subcutaneous plexus. The subcutaneous layer, connective tissue fibers of the reticular layer are extensively interwoven with those of the subcutaneous layer, or the hypodermis. The boundary between the two is generally indistinct. It's important in stabilizing the position of the skin in relation to the underlying tissues, such as skeletal muscles and other organs, while permitting independent movement. Subcutaneous fat. Most infants and small children have extensive baby fat. Helps them reduce heat loss. Subcutaneous fat also serves as a substantial energy reserve, also serves as a shock absorber for rough and tumble types of activities in the early years. As we grow, the distribution of our subcutaneous fat will change. This is an illustration from your book that now identifies one of the surface appendages that we see in the integumentary system. This is a hair shaft. You should be able to identify the structures of the hair shaft. The shaft of the hair itself, the exposed hair shaft, the one that lies below the surface. Then there is also the root of the hair. There is the hair bulb, the hair papilla, the blood vessels that supply the hair. This muscle, the erecti pili muscle, is what allows hair to stand on end in states where you may be anxious or excited. And then the sebaceous gland, which provides oils and secretions that follow up to the surface, basically because this is a patent duct. Now there are different types of hair. We'll talk about each of those. Lanugo hair. This is hair that first appears after the first 3 months of embryonic development. These hairs are known as lanugo hair. Extremely fine hair. It's unpigmented. Most of these hairs are shed before birth. This is another illustration of the hair follicle. This is a histological slide of the hair follicle that you should be able to recognize for the purposes of your anatomy lab. You should be able to identify the structures as listed on this slide. There's also villus and terminal hair. Lanugo hair is basically replaced by one of two types of hair in the adult integumentary system. One is villus hairs. Villus hairs are the fine peach fuzz hairs located over much of the body surface. And then the more mature or coarser hair is referred to as terminal hairs. Terminal hairs are heavy, more deeply pigmented, sometimes curly. Hairs on your head, including those on your eyebrows, eyelashes, are all terminal hairs. Now, hair and hormones. Hair follicles may alter the structure of the hairs in response to circulating hormones. Villus hairs are present in armpits, pubic area, limbs until puberty. Thereafter, follicles produce terminal hair in response to circulating sex hormones. As far as hair color, variations in hair color reflect differences in the structure and variations of pigment produced by melanocytes in the hair papilla. Different forms of melanin give dark brown, yellow brown, red color to the hair. These structural and biochemical characteristics are genetically determined. Hormonal and environmental factors can influence the condition of the hair. Gray hair, as pigment production decreases with age, hair color lightens. White hair results from a combination of lack of pigment and the presence of air bubbles in the medulla of the hair shaft. As the proportion of white hair increases, individual overall hair color is described as gray. Hair dyes and treatment. Now, color treatment for damaged hair by disrupting and protective cuticle layer and dehydrating or weakening the hair shaft. As a result, the hair becomes thin and brittle. The function of the hair, roughly 500,000 hairs are on our head and protect our scalp from ultraviolet light. It also helps cushion is a light blow to the head may be lessened by some of the insulation that is given by the hair. It also can insulate the skull. It guards the entranceways of our nostrils and external ear canal. It also prevents the entry of foreign bodies into our nose and into our ear. Eyelashes perform similar functions across the surface of the eye. Hair also has a sensory function. The root of the hair, or the root, or a root hair plexus of sensory nerves, surrounds the base of each hair follicle. You can feel the movement of the hair shaft, even of a single hair, due to the sensitivity of those nerves. Sensitivity provides an early warning system and may help prevent injury. An example is that you may be able to swat a mosquito as it lights on the surface of the skin because it touches the hair first, so you're able to swat it away. As far as responses to stimuli, there are ribbons of smooth muscles called erectopili muscles that extend from the papillary layer of the dermis to the connective tissue sheet that's around the hair follicle. Now, I showed you the erectopili muscle in an earlier illustration, so you should be able to identify that structure for the purpose of the lab. When stimulated, the erectopili muscle pulls on the follicle and forces the hairs to stand erect. Contraction may be the result of an emotional state, fear, rage, or in response to cold, which basically produces goosebumps. Also, static electricity may cause the hair to stand on end as well. Now, this is more a response of the static electricity and not so much a response of the erectopili muscle, though the standing of hair on end may stimulate the erectopili muscles to contract. Hair production and follicle structure. Hair production involves specialization of keratinization. It begins with the deepest part of the hair follicle. The epithelial layer involves the hair matrix. Hair production. Basal cells near the center of the hair matrix divide, producing daughter cells that are gradually pushed toward the surface. Those cells closest to the center of the matrix forms the medulla. Cells closer to the edge of the developing hair form the cortex, and those at the outer margin will form the cuticle. Hair production. As cell division continues at the hair matrix, the daughter cells are pushed toward the surface of the skin and the hair gets longer. Keratinization is completed by the time these cells approach the surface. At this point, which corresponds to the start of the hair shaft, the cells of the medulla, cortex, the cuticle are dead, and the keratinization process is at an end. The epithelial cells of the follicle walls are organized into several concentric layers outward from the hair cuticle. These layers are the internal root sheath, the external root sheath, and the glassy membrane. Again, this was shown to you in earlier slides, and I would expect you to be able to identify this in your lab. The internal root sheath surrounds the hair root and the deeper portions of the shaft. The internal root sheath is produced by cells at the periphery of the hair matrix. The cells of this sheath disintegrate very quickly. This layer does not extend the entire length of the follicle. The external root sheath, longitudinal sections extend from the skin surface to the hair matrix. Over most of the distance, it is all cell layers found in the superficial epidermis. However, where the external root sheath joins the hair matrix, all the cells resemble those of the stratum germintivum. Glassy membrane, basically thickened basal lamina wrapped in a dense connective tissue sheet, is representative of the glassy membrane. This membrane is in contact with the surrounding connective tissue of the dermis. Growth and replacement of hair. Our hair grows, or as our hair grows, and is shed according to a hair cycle. A hair in the scalp grows for about 2 to 5 years at a rate of about 0.33 millimeter per day. Variations in the growth rate and in the duration of hair growth cycle accounts for an individual's differences in the length of the uncut hair. Now, diagnostic hair, again, those of you who follow CSI will appreciate this. Cells of a hair root absorb nutrients and incorporates them in the hair structure. Collecting hair for analysis can be helpful in diagnosing several disorders. Hairs of individuals with lead poisoning, for example, or other heavy metal poisonings contain high quantities of those metals. Hair samples can also be used for identification purposes and DNA fingerprinting. Certain drugs that are administered to individuals, whether legal drugs or illegal drugs, can be measured. At least the content of that drug in the system can be identified by analyzing the hair. Hair loss, especially in males. This is a huge industry, and again, millions, if not billions of dollars are spent each year. To prevent hair loss or to stimulate hair growth or to replace hair. Changes in the level of sex hormones circulating in the blood can affect the scalp, causing a shift from terminal to villous hair. Now, if you switch from villous to terminal hair production, it will alter the amount of hair that is in a particular region of the scalp. We typically see this occur around the temporal area and the crowns of the head more often. This alteration is referred to as male pattern baldness. This also can be have a hereditary link as well. The pattern of baldness may be seen in siblings or certainly in the parents of the individual who's affected. Temporary causes of hair loss. Temporary increases in hair loss can result from drugs, the dietary factors, radiation, excess vitamin A, high fever, stress, and hormonal factors related to pregnancy. A good example is receiving chemotherapy and or radiation therapy, which sometimes can cause hair loss. Typically, the hair will regrow after the toxic levels of the various drugs have been removed from the system, and the hair growth will resume. Now, there are a number of glands that are involved in the integumentary system. We'll touch upon some of those glands at this time. Skin contains two types of exocrine glands: sebaceous glands, which produce an oily lipid that coats the hair shaft and the epidermis, and then sweat glands, which produce a watery solution and perform special functions. Sebaceous glands and follicles, again, this illustration is taken from your textbook. Histologically, I would expect you to be able to identify these for the purposes of the lab. These sebaceous follicles can be illustrated here now. This is a cross-sectional view and an actual histological slide of a sebaceous gland. You can see the various compartments, the lumen, again, which leads to the outer surfaces. You can also see the contents of each of the glands as it is lined up in the follicle. Sweat glands, or apocrine glands, apocrine sweat glands, are located in the axilla, the groin, the nipples, and produce thick, odorous fluid. Apocrine sweat glands begin secreting at puberty. The sweat produced is a nutrient source for bacteria, so it can sometimes involve an intensity of odor. Special myoepithelial cells surround the secretory cells in these glands. Myoepithelial cells contract, squeezing the glands and thereby discharging accumulated secretions into the hair follicle. American sweat glands. American sweat glands produce a watery fluid, more numerous and widely distributed than you see the African sweat glands. The adult integumentary contains about 2 to 5 million American sweat glands. This is a histological slide illustrating the African sweat gland. Again, you can see the arrangement of the cell type in these glands, the lumen, connective tissue proper, the myoepithelial cells. Again, this is the African sweat gland. This is a cross-sectional picture of the integumentary system, specifically identifying the American sweat gland and the African sweat gland. This is an illustration of the American sweat gland. Again, you can appreciate the myoepithelial cells, the various lumen. Again, I would expect you to recognize sweat glands in a histological slide. The functions of the American sweat gland activity include cooling the surface of the skin to reduce body temperature, excreting water and electrolytes. A number of ingested drugs are excreted as well. It also provides protection from environmental hazards. Sweat basically dilutes harmful chemicals Sweat dilutes harmful chemicals and also discourages the growth of certain microorganisms in a couple of ways. First, it flushes them off the surface. It makes it difficult for them to adhere to the epidermal surfaces. Number two, through an action referred to as a dermacidin, this is a small peptide that has powerful antibiotic protection or antibiotic properties. There are specialized glands as well. The mammary gland, which we'll discuss more in the reproductive system, and ceruminous glands. Mammary glands basically are breasts that are anatomically related to the African sweat gland. A complex interaction between sex hormones and pituitary hormones help to control the development and secretion. Ceruminous glands are modified sweat glands in the passageway of the external ear. Their secretions combine with those of nearby sebaceous glands, forming a mixture of cerumen or earwax. Together with tiny hairs along the ear canal, earwax helps to trap foreign particles, preventing them from reaching the eardrum. Homeostatic role of the integumentary system. Glands are collectively turned on and turned off by the autonomic nervous system, but no regional control is possible. When one sebaceous or apocrine gland is activated, all of the other glands, the same type of the body, are activated as well. American sweat glands are much more precisely controlled, and the amount of secretion and the area of the body involved can vary independently. This ends the lecture on the integumentary system, and this ends this session for today. The next lecture will be on the musculoskeletal system, specifically addressing the skeletal system. Thank you.